Hello. In this episode, we continue our discussion of environmental exposure-related interstitial lung diseases by focusing on hypersensitivity pneumonitis and smoking-related ILDs. Now, what is the pathophysiology of hypersensitivity pneumonitis? It is a combination type 3 and type 4 hypersensitivity reaction to organic environmental antigens, including mold and animal proteins. Now, when we see a combination hypersensitivity reaction, what is specifically the findings associated with each type? We have immune complex mediated type 3 and granulomatous type 4. So please add this to the other granulomatous interstitial lung disease, sarcoidosis. This is important in terms of differential because you may have an interstitial lung disease pattern of pulmonary function test and you are said to have a granulomatous biopsy. Sarcoidosis and hypersensitivity pneumonitis would be the top of your differential. On the other side, you may have the again interstitial pattern pulmonary function test, but you are said to have environmental exposure. Now, the pneumoconiosis and hypersensitivity pneumonitis subtypes are your differential, and the way you distinguish them is that in hypersensitivity pneumonitis, contrary to pneumoconiosis, we are mainly dealing with organic animal substances as the source of exposure, and also we have the seasonal pattern. Now, what are the common subtypes of hypersensitivity pneumonitis? We have farmer's lung, bird fancier's lung, mushroom worker's lung, potato riddler's lung, wine and cheesemaker's lung, and hot tub lung. But at the end of the list, also remember we have chemical worker's lung, which makes the differential very challenging with the pneumoconiosis. Now, so let's begin right there. What type of chemical exposure can cause hypersensitivity pneumonitis? Because that will possibly be our only clue to differentiate it from certain pneumoconiosis. Remember, dyes and varnishes like the solved resins for shining material, as well as spray paints. Now, when we talk about farmer's lung, what is the causative agent? Thermophilic actinomycetes and Aspergillus species, the moldy hay is the underlying cause. Likewise, in bird fancier's lung, the dropping or feathers of the avian animal contains the protein that mediates hypersensitivity. How about hot tub lung? Remember, Mycobacterium avium complex and Cladosporium species mediate hot tub lung. Now, if you are asked what types of hypersensitivity pneumonitis could be caused by thermophilic actinomyces, what are the three conditions? One is the farmer's lung, the other is the mushroom worker lung, and the other is potato riddler's lung. It's simple, all three of them are related to some farming activity. Now, if you are asked Aspergillus could mediate what types of hypersensitivity pneumonitis, remember farmer's lung as well as cheesemaker's lung. And finally, botrytis could resemble bottle, so it's associated with winemaker lung as the hypersensitivity pneumonitis. Describe the clinical presentation of acute subtype of hypersensitivity pneumonitis. The acute type is mainly a lymphocytic pneumonia. So we have abrupt onset of fever, chills, leukocytosis after exposure to the causative particle. So these episodes could be recurrent, but they are usually self-resolving. Now, what's the chest x-ray pattern of acute lymphocytic pneumonia seen in acute subtype of HSP? We have interstitial opacities that are defined as scattered or micronodular. What about the symptoms and chest x-ray findings in the chronic type hypersensitivity pneumonitis? The symptoms resemble that of TB with postural dyspnea, fatigue, weight loss, and progressive chronic cough. Now, what are the chest x-ray findings? We have the typical features of fibrosing lung disease, that's reticular pattern or honeycombing pattern. It is far more advanced than just the scattered micronodular pattern seen in the acute type. Now, we mentioned both types could show some degree of dyspnea, so how do we differentiate the pattern of dyspnea? The dyspnea in the chronic type is more progressive and could be associated with even hypoxemia on exertion. How the biopsy of acute versus chronic type hypersensitivity pneumonitis differ? While in the acute type, we logically have lymphocytic infiltrate. In the chronic type, we have interstitial inflammation and fibrosis. In both type, however, could have non-caseating granuloma. Now, what are the findings in other tests? Well, we have, again, restrictive pattern pulmonary function tests with decreased DLCO as seen in interstitial type restrictive lung disease. And also notably, bronchoalveolar lavage shows increased lymphocyte count. Describe the management of hypersensitivity pneumonitis. For both types, the cornerstone of treatment is exposure avoidance to the allergen, or I should not call it allergen because it is not a type 1 hypersensitivity, but the agent causes the hypersensitivity. For the acute type, we can consider corticosteroids, but for the chronic type, if it's becoming progressive and non-responsive to corticosteroid, lung transplant is the only definitive diagnosis. Now, very important, true or false question. Smoking cessation is highly recommended and helpful for preventing the progression of or worsening the course of hypersensitivity pneumonitis. I don't know how to put it, but no, actually, smoking has shown to be protective to whatever chemical reactions. Smoking reduces the risk. So it is not part of the treatment. However, of course, you should recommend every patient to lower their smoking habit, and cessation of the smoking is the goal given all the risk associated with it. So this was just a true or false question to know the emphasis on smoking cessation is not necessarily the cornerstone of preventing the progression of the disease from a purely theoretical or pathophysiological perspective. Now, do you remember what specific types of interstitial lung diseases have smoking as a synergistic risk factor of worsening the disease? Of course, one is asbestosis transitioning to bronchogenic carcinoma, and the other is idiopathic pulmonary fibrosis. Now, how do we differentiate these environmental exposures seen in hypersensitivity pneumonia, or pneumonitis I should call it, from the asthma, which is also a condition with respiratory symptoms after environmental exposure? Remember that even though both of them could be associated with episodic symptoms after environmental exposure, asthma not only demonstrates history or family history of atopy and type 1 allergic reaction, but also it shows an obstructive pattern spirometry in which we have improvement of FEV1 with short-acting bronchodilators, while in the case of hypersensitivity pneumonitis, the pattern of respiratory function test is that of restrictive or interstitial lung disease. A very important differential diagnosis is a patient whose pulmonary function test is restrictive pattern and the chest x-ray shows granuloma, or the biopsy shows patterns compatible with non-caseating granuloma. What are the differential diagnoses? Well, hypersensitivity pneumonitis. Don't forget, among the pneumoconiosis, berylliosis and to some extent sarcoidosis are also associated with granuloma formation. The top of the list, of course, is going to be sarcoidosis. And again, don't forget silicosis. And at the end, don't forget Wegener's granulomatosis. We mentioned any vasculitis associated with lung disease would be associated with restrictive pattern lung disease most commonly. Now, we have a patient with eosinophilia and respiratory symptoms. What are the conditions that you should think about? One is asthma, if there is obstructive pattern. The other is eosinophilic lung disease, especially eosinophilic pneumonias. We will discuss them in our final episode of interstitial lung diseases. Now let's turn our attention to the smoking-related interstitial lung diseases. Just a couple difficult names, but pretty straightforward differential diagnosis. So if you have restrictive lung pattern in a heavy smoker or long-term smoker, what are the two differential diagnoses that you should think of after ruling out, of course, other causes of smoking-related lung disease, or if you have any biopsy confirmation? Two smoking-related interstitial lung diseases are DIP and RB, that's Desquamative Interstitial Pneumonia and Respiratory Bronchiolitis. Now, in addition to the smoking history, what is the most important finding? The finding is what we have in the biopsy, and that is presence of pigmented intraluminal macrophage accumulation. So how do we differentiate these two? If the macrophage accumulation is reported to only involve the alveoli, that's DIP, Desquamative Interstitial Pneumonia. While if it involves primary and secondary bronchioles in addition to possible alveolar involvement, that's logically called respiratory bronchiolitis. What about their management? Both have good prognosis upon cessation of smoking and, if needed, corticosteroids. And this finishes our environmental exposure associated with interstitial lung diseases. The previous episode of environmental exposure, we discussed pneumoconiosis. Thank you.